All right, good afternoon, folks, and welcome to the Public Health Science Echo, where the public has the opportunity to ask science-based questions for our public health team. This session is produced and facilitated by UAA's Alaska Echo Project in partnership with the Department of Health and Social Services. My name is Erin, my pronouns are they, them, and I'm with Project Echo. For those joining us on Zoom, questions may be entered into the Q&A feature. For those joining us on Facebook, please add your questions in the comment section and they will be shared with our panelists. As a reminder, we do expect all participants to keep questions and comments on topic, to be considerate, and to use language that is respectful. So thank you for that. If your internet connection does not support audio, you may join us by phone by calling the phone number we've entered in the comment box along with the meeting ID. Closed captioning is available as well. You can access this by selecting the CC button on the bottom of your Zoom screen. And lots of thanks to our captioner today. I'd also like to note that the opinions expressed in this session are those of the speakers and do not necessarily represent those of UAA, DHSS, or any of our ECHO sponsors. Our hub team should all be familiar faces by now, so in an effort to maximize our time together today, we'll go ahead without introductions up top and instead proceed directly to our presentation. Hub team members, if you could just introduce yourself during the Q&A session before answering any questions, that would be appreciated. So without further ado, I'll go ahead and hand it over to Dr. Zink.
Hi, everyone. Dr. Ann Zink here, Chief Medical Officer. Thanks for tuning in. I already see the questions popping in the chat box, so thank you for putting them there. We really appreciate a two-way dialogue with you all, and thanks for the team for showing up. Erin, one of these days we're going to calculate how many of these we've had, but it's a year and a half in, almost 2 years in, and so appreciate the public being engaged. I'm going to go through some slides quickly. Thanks to the public information team for sharing these slides and helping to put them together on current topics. You know, a lot of these slides are usually put together on topics that we're hearing from you all over the past week and questions that we're getting on social media and email and other places to try to make sure that we're responding to the questions that the public have overall. So always starting nationally, here's kind of the case trend nationally. So you can see, you know, big wave in November and the kind of the uptake that we see now. I always caution people to look at the most recent line because that may be reporting. It takes a while for these cases to be reported in. So we'll continue to see where this is going nationally, but hoping to start to see a downward trend here sooner rather than later nationally. Here is Alaska's data, and remember to please look at the onset tab instead of just the report tab because it does take a while for cases to actually be run on a test, be reported to us, for our team to enter them. And so really when you're looking at the epidemiology of your community, looking at the onset is going to be more reliable than the test date. Also realizing that the most recent days are going to be slow and lower just because it takes a while for those tests to be reported in. And you can go ahead and select per region if you're interested in your region overall. However, the color is pretty consistent across the state. We are pretty red. And so again, more than 100 cases per 100,000 gets us in that high alert level. And we are at 565 cases per 100,000. We have a lot of COVID. Think of it as bad weather. We got a lot raining right now. There's a lot happening. The difference between weather and COVID is that we have the ability to control it. And that is each of us on a daily basis making decisions to slow the spread of this virus in the actions we do, such as getting vaccinated, getting tested early at symptoms, and minimizing our contact as well as masking. So that is the difference between weather, but we have a lot of COVID right now. We've had a 12% increase this week compared to last week overall. Today, 808 new cases. Again, some backlog in there, but the team is still working through additional backlog, and we're happy to answer more questions about that. And starting to approach this 90,000 Alaskans have tested positive for COVID-19 overall. You can see our percent positivity remains elevated at 8.2. Ideally like to have that less than 5. This helps to identify cases early. And the higher this percent positivity, the more cases that we know that we're missing. So thank you to all of you who may have waited in lines to get tested, struggled to find a testing site. We know it's not as easy as we would like it to be and continue to do what we can to improve the testing availability. Remember that there are at-home tests that you can purchase as well as testing that you can get at many grocery stores. The availability of them kind of waxes and wanes depending on national demand. And right now there's a lot of national demand, but we continue to do what we can to support testing in every community across the state. Vaccines still remain our best tool to minimizing this impact of this virus on our health. Really help to minimize the risk of hospitalization and death. And it's great to see 61.4% of Alaskans 12 and above have started their vaccine series. We'd love to see that higher. the data continues to come out that communities that have low vaccine rate have higher hospitalization, higher death, and more cases. And so overall, vaccines are our best tool. They're not a perfect tool, but they're like a seatbelt. They work pretty darn well and are important to do in combination with other things when we've got a lot of COVID circulating. We did see an uptake. You can see July kind of was pretty low here and up into August. These most recent data, or these gray ones, are a little bit grayed out in comparison just because it takes a while for report in. A week ago, we'd been up 46% compared to the week before. That slowed down a bit. So we've slowed down to like 21% compared to the week beforehand. So just want to continue to encourage Alaskans to talk to your primary care provider, talk to a pharmacist, talk to your healthcare provider, ask us questions if you've got questions about the vaccine. Here is COVID vaccine rates by age group across the state. So the green is 12 and above, the white is 65 and above, and the yellow is all ages. We have some regions that have just a lot more kiddos than other regions in the state, so that really can influence that number. So you can see overall 12 and above, we're just almost at 61%, 65 and above is 76%, and of all ages, we're just over that 50%. And you can see that there's a large variety in regions based on the percent. So it's pretty cool to see. Here we got Bristol Bay is at 91% of those 12 and above have received at least one shot of COVID-19 vaccine. So we see some regions that are really highly vaccinated, and so big kudos to them overall. We have been doing a bunch of survey work to try to understand why people are getting vaccinated or not, and our team is on to answer more questions about this overall, but we did do an additional survey in June through July, and we asked questions about, knowledge, attitudes, beliefs regarding COVID-19 vaccine, and it was asked to be a phone number. There were 907 unvaccinated respondents and 227 vaccinated respondents, but this does not reflect the overall vaccine rate, but they were really trying to aim for unvaccinated folks to understand the reasoning for unvaccinated. So looking at those who are unvaccinated, 58% said that they may do so. So I think this is encouraging news. There's still quite a few people out there who may do so, and they want more information. They don't realize how bad it is. They didn't know where to get it. There's all sorts of reasons for it. But we do have a pretty strong group who is definitely not going to get it. And, respect people's individual choices. This is not a shaming exercise. This is just a chance to provide information and better understand how we can be able to provide tools and resources to get people the information that they need and are looking for. Alaskans that definitely not planning to get vaccinated were more likely to perceive themselves at no risk for COVID and severe illness. And I think this is something clinically that we see all the time. Again, we're happy to go through the additional data that really shows that if for every age 12 and above, COVID presents greater risk to the individual than the vaccine, and happy to kind of go through that data overall. But you can see kind of the different ages and their perception of severe risk versus infection. And then main reasons. There's a lot of main reasons why people are not intending to get vaccinated this time. So lack of information and access continues to be there for those who definitely want to get it but have not gotten it yet, versus those who are getting a lot of misinformation are definitely not planning to get it. So you can see that continuing lack of information and access and time continues to be an overall issue. The other thing that I thought was interesting here for definitely or probably yes, can get it, a lot of questions about reproductive health. And so again, encouraging people to talk to their OB, their pediatrician about any questions or concerns you have about reproductive health is really important. A couple other additional points about vaccine. Again, those who are immunocompromised are recommended to get a 3-dose series of the mRNA vaccine, and so can do that now. In immunocompromised being organ or stem cell transplant, people are fighting an HIV infection, active cancer treatment, or taking medications that weaken the immune system. And then regarding a booster dose, or people who've been previously vaccinated and may need an additional dose because of waning immunity, we're really waiting on the FDA to review that data and the ACIP to review that data. We are planning for ability to do that. And we've all heard a lot of messaging from the White House about, mid to end September being able and ready to do that. And we want to make sure that we're ready, but we also want to make sure that we're following the data and science and waiting for the FDA and the ACIP on that topic. So as soon as we have more information on that, we'd be happy to do that. Hospital capacity has been the topic of the month, honestly. We are seeing a lot of patients being hospitalized because of COVID-19 right now. Our hospitals are stretched incredibly thin, and we've got part of our hospital capacity team on this echo to make sure that we're responding to questions that you have. You can see that we're reaching new levels of the percent of patients that are hospitalized because of COVID-19, as well as the total number. So currently 21.3% of everyone in an Alaska hospital right now is because of COVID-19. I was just looking at Matsu's data yesterday, and over 50% of the patients hospitalized at Matsu right now are because of COVID-19. So really seeing a large burden on some of our hospitals, with almost 200 patients being hospitalized and 26 on vent. What is kind of striking and fascinating to me is just the difference between vaccinated and unvaccinated individuals. So nationally, unvaccinated people are about 17%, in fact, 17 times more likely to be hospitalized due to COVID-19. And here's, actually, I don't think it's quite on that one. I'll just stop here on this. When we looked at July's data, the average person who was vaccinated and hospitalized was 14 years older than the average person who was unvaccinated and hospitalized. When talking to some of the major hospitals in Anchorage this weekend, one hospital, it was 44 was the mean age of someone who was hospitalized and unvaccinated for COVID-19 versus 66 was the median age of someone who was vaccinated and hospitalized. So we're seeing those who are vaccinated, who are being hospitalized, are much older with many more comorbid conditions versus those who are younger, who are unvaccinated. So it's really becoming this tale of two worlds. Even just clinically this weekend, working, 45-year-old healthy individual, unvaccinated, super sick, admitted, and an 88-year-old chronically on oxygen, also got COVID, vaccinated with a slight oxygen requirement. Just that shift, I admitted 2 patients, half of them were vaccinated. One was vaccinated, one wasn't. But the difference clinically between those patients is just striking between their underlying health conditions. And so I think we're kind of seeing these kind of tale of two worlds. But overall, as we have a lot of COVID spreading, a lot of people being hospitalized because of COVID. This is also a striking figure to me. So the purple line is the 0 to 19, and this is our cases per age at week onset. And so you can see that 20 to 39-year-old age group really in November, kind of a lot of cases there, followed by the 40 to 49. And then that 0 to 19 is that purple line below it. But you can see more recently that purple line is skyrocketing above that 40 to 59 group and starting to catch up with that 20 to 39 age group. So lots of kids in general tend to do much better, but we are seeing more kids being diagnosed. And this is another way looking at Alaska hospitalizations by admission date overall. And again, these slides are public and happy to share them. Schools, our schools in session, it's great to have kids in school. It's where they learn best and want to do everything we can to support our kids for in-person learning. Here is information from one district that had universal masking, and they did some estimates based on contacts with and without universal masking. And what you can really see is that universal masking kept kids in school. So even with positive cases in school, their average close contacts decreased to 2.5, resulting in about 7,100 days of students needing to quarantine versus the estimation with no masking that increased to 16,740 days of quarantine with no masking. So again, masking in schools not only is a way to slow the spread of COVID-19, but to keep kids in school overall. Just an update on testing, continue to test as I spoke about earlier. We continue to ship rapid testing. We are seeing more supply chain limitations across the nation in this, and continue to work directly with the companies as well as the federal government for rapid testing to make sure that supplies are available. Airport testing is continued, and that includes rapid testing as well as PCR testing. And most areas have turnaround time less than 48 hours. That is longer than like the 12 to 24 hours that we were initially seeing earlier. We are getting reports of a lot of long lines and working with communities to do what we can to speed up those long lines to get you back to work and school and the other places that need to be moving. Regarding healthcare capacity, lots of things are happening in this space, including expedited license and background checks, assessing the ways that temporary hospitals can increase staffing, including specifically asking for a bunch of GSA support staff, additional nurses to potentially come up here and work. The governor did introduce a bill last Thursday specifically to address some telemedicine and licensing issues to, again, try to get services up here as quickly as possible, working with the hospitals on what were the needs. And those asks could not be done via a disaster declaration, could only be done via a statutory change. And that's why that was introduced. And then we continue to work to procure medical supplies, as mentioned previously, testing, and also try to achieve cost savings by bulk purchasing. But at the end of the day, this is a bunch of Alaskans making individual decisions to keep each other healthy and safe, and doing what you can the moment you get symptoms, getting tested, isolating, letting your close contacts know, as an entire system is behind and delayed overall. Continue to see a predominant drive from Delta variant, and our weekly report on the surveillance continues to come out. Continue to provide information on breakthrough cases in general. And so when we're looking January through August, the vast majority, 82% of our cases are in unvaccinated individuals and 89% of all of our hospitalizations. But as mentioned previously, and I think it's on the next slide, here we go. If we look January through July, again, 10% of our cases are in unvaccinated individuals, 10% of our cases are in vaccinated individuals, 90% in unvaccinated, and similar for hospitalizations, 8% vaccinated, 92% unvaccinated. But you can see in July that's starting to change. We've had more individuals who have had vaccine have breakthrough cases in July, as well as an increase in people who are being hospitalized. This is probably a combination of both Delta variant as well as just waning immunity, which happy to talk about more, as well as the fact that we got a lot of COVID spreading. We are at high risk for those who are elder, those who have been able to protect themselves in other ways for getting COVID-19. Here's another graph showing just a 7.5 fold reduction overall in hospitalizations per 100,000 age adjusted for those who are vaccinated and unvaccinated. I continue to see patients who clinically choose other treatment options early on in their disease course. Our best treatment option, both for vaccinated and unvaccinated individuals who are high risk for severe complication for COVID-19, is monoclonal antibodies. And if you're having a hard time finding them, please call our call line at 646-3322. And as always, we have a speakers bureau, and many of the people you see on this call do these calls on a regular basis to answer your questions about COVID-19 and be able to provide additional information. And our same line stands up for finding vaccines. So if you're interested in getting vaccinated, need an interpreter, have a friend that you're trying to get vaccinated. As many people know, the chamber had money to be able to help support their community. When they looked at the overall impact of COVID on their businesses, they decided that the best way that they wanted to use that money was to give AK a shot. And that was from this lottery to be able to reward vaccination. So you can enter to win $49,000 and a scholarship, a 529 scholarship, if you're vaccinated. And every week on Thursday, there's a drawing for that. So take a look at the Give AK a Shot from the Alaska Chamber to encourage vaccines. And remember, in the meantime, well, we got a lot of COVID. We're used to layering our clothes. We're used to adding our snow tires to our car when it gets icy. So please do what you can to layer your mitigation protection, vaccination, masking, distancing to help keep yourself and your community safe so we can keep our kids in school and our hospitals open. So with that, I will stop and turn it over to questions. Thanks.
Excellent. All right, so let's start here. Could you help shed light on the CDC announcement ending PCR testing? This participant quotes, CDC encourages laboratories to consider adoption of a multiplex method that can facilitate detection and differentiation of SARS-CoV-2 and influenza viruses. Dr. Cutchins, perhaps?
Sure. There's been a lot of misinformation about this statement, but I really want to shed into light what it is. So early in the pandemic, there was no test for SARS-CoV-2 virus. So CDC made one. They made a product. They had to submit to the FDA, who's the governing board for medical tests, and the FDA approved it. Then they made this product. It was widely available. Just like any other manufacturer, when they stop making something, have to notify the FDA that they're going to stop making it. The reason they're stopping making it is because there's over 250 commercially available products now for testing for COVID. The CDC does not need to make one because they're not a drug manufacturer. This product that they're making tests for one thing. It tests for the SARS-CoV-2 virus. That's the only thing that'll detect a positive. They are continuing to make their other assay that tests for three things: COVID, flu, and RSV. 3 tests, 3 different answers, where the single assay is 1 test, 1 answer. So it's nothing to the performance of PCRs. It's just the fact that they're removing this product from the market. Dr. Parker, would you have anything to add to that? I saw you were on.
Yeah, I would just add that the SARS, flu, and potentially RSV assay that they are producing and sending out to public health labs and others is also a PCR assay. It's just basic methodology for how those things are detected. So they're both PCR assays. They're just asking this season, as they sunset their older assay that we really look at flu and SARS together for this coming season.
All right, thank you so much, Hub Team. So let's talk a little bit about data. We've had a few questions regarding data collection, and specifically several that wanted to know about whether or not the state collects information about the vaccine status of both positive cases and death. Is that information that the state is currently compiling? Is that something that can be updated daily and sorted by frequency? Thanks so much.
Oh, hi, Erin. This is Joe. I can go ahead and start with that. So yes, we do have, I'm going to go ahead and share my screen. We have a report that is coming out roughly monthly. It's COVID-19 update, hospitalizations, deaths, and vaccine breakthrough infections. And this most recent one is through July 2021. And it does show the proportion of cases per 100,000. Now, this is shown as a rate that are fully vaccinated versus not fully vaccinated. And so I can provide a link to this report in the chat box.
And we've got, sorry, I was gonna say, do you want to talk a little bit about like the daily reporting and why the challenges are there and why we can't really report out cases on a daily basis for vaccine status and a little bit what that looks like?
Yeah, sure. Thanks. So, we put together this monthly summary because it's a way to make sure that we can really go through all the data, especially the hospitalizations and the deaths, go through the medical records and really verify vaccination status and clinical situations. So every day that we're putting out those case numbers, like the 808 that was reported out today, those are people who may have been sick over a week or something like that, and their hospitalization event might not actually happen until the future. Their death is obviously not going to happen until the future, and so it's really challenging on a daily basis to give those to sort of annotate each case with their situation because a lot of it hasn't happened yet. It's a lot more, I think it's a lot more useful and instructive for trends if we can compile all that data and verify all that data and put that out on those monthly summaries. I think it had been mentioned before that the cyber attack had impacted the death certificate database situation, and they're catching up now as they're able to sort of, dig into that backlog. And that's also why on that report that Joe's going to send you the link for, there's limited information about the deaths, just because we know those haven't been fully captured at this point. So I think that's what I'll say. Thanks.
The only other thing that I would add to that is like there's lots of places where data gets filtered or doesn't always cross. So, like when I'm working in the hospital, the nurses enter all this data about vaccine status, symptoms, and things like that. Our team at DHSS doesn't get any of that data. They just get positive or negative in the same sort of way. So even if you're asked that information, doesn't always mean it crosses all the way over and then crosses back out because of all sorts of patient protection rate issues and data crossing and all sorts of IT challenges that have been kind of the bane of this pandemic. But I want people to be aware that just because you may be asked that information at a clinician level, it doesn't always cross to us and we don't have that data immediately available.
All right, let's see. So is the state tracking early vaccinated healthcare workers for positive tests and lengths of efficacy of vaccines versus the Delta variant's impact on those?
Yeah, Joe or Louisa, it's kind of in that vaccine breakthrough data-ish.
I think we're in tracking vaccine breakthroughs. I think we're interested in a whole lot of questions. Some of the data that had been presented in that report really shows you, timeframes like through June and then July when we think when Delta sort of took off and really kind of change what was going on with the pandemic. We're very interested in that interval from when did people get vaccinated to when they might have an infection. We're also interested in reinfection cases as well. So there's a lot more to explore on that. I think, a lot of healthcare workers, a lot of the elderly also were those first group of folks to start getting vaccinated in December and January. And those are ones where, we had seen such an impact to protection for them. And now we're starting to see, cases creep back up in that age group, and that makes us really concerned about waning immunity as well. So I think placeholder for lots more information to come on things like duration from or interval from series completion to infection in the future.
The only other thing that I would add to that too is it can, and Louisa, correct me if you feel differently, it can be really hard to determine the source of someone's infection. So we get a lot of times, like, we're seeing more healthcare workers getting sick at work, but healthcare workers also like have kids and they go to restaurants and they do things as well. And so identifying that actual cause of their infection, particularly when we have so many cases spreading, can be really challenging. So when we've tried to pull out work profession, it can be really hard. Date of vaccination for waning immunity is easier to look at, but when we're looking at job class, I want to temper expectations there, because people have jobs, but they're also human, and it can be really hard to identify the cause.
Yeah, I think that's really important. It's also, you sort of spoke to this as well as far as exposure. It's when somebody has symptoms, you can sort of, put a pin on the calendar and say, okay, great, this is when this person started getting sick. Now I kind of know when exposure is. If you've got people like healthcare workers or others who are getting screened for their workplace and they're asymptomatic, then you have a much fuzzier window for when they possibly, acquired that infection. So those are other things to take into account with, especially with healthcare workers.
All right, so relatedly, we do have a question that asks, this participant says that as of late August, there are more cases in people under 20 than any age group. Can our hub team answer the question as to whether or not this is because of school starting, and what changes are we seeing in terms of hospitalizations in that under 20 age group?
I can take that one.
Oh, go ahead. Yeah, please, Michelle.
So from a clinical standpoint, we are seeing more cases. In the past 2 weeks, there's been a 10% increase just nationwide in the number of kid cases that we've seen. And if you've seen on the news, we are seeing more pediatric hospitals and intensive care units being overwhelmed and having to shuffle and decide where kids may go. So we are seeing this, and it's a statistic that is out there. Regarding the case, I think it's one is school is back in session. So you do have more transmission, and some are wearing masks and some are not, and some are following CDC guidelines and not. So that is going to impact. Plus, with the number of kids under 12 that are not vaccinated, that is a source of more transmission because of a large group that's not being vaccinated. So, Joe, did you have additional to add on to that?
No, I think you hit all the major topics. One thing I did want to just share with folks is there is an MMWR that came out. It's a early release MMWR that looked at really hospitalizations and more severe infections among children. So this is really helpful information. This figure looks at the number and percentage of COVID-19 hospitalizations resulting in intensive care unit admissions for invasive mechanical ventilation. So what you see in the bars here is the number of COVID-19 hospitalizations going back December, January 2020, 2021, we had that big spike and then a decrease. And now we've got this big spike again with the Delta variant. Here you have the age groups. The lightest blue is 12 to 17, and then followed by 5 to 11, and then 0 to 4 with the darkest blue. But now take a look at these lines. So here's the percentage with ICU admission, 0 to 17 years. And basically you're seeing a pretty steady, actually it's dropped a little bit, but CDC has said that, that it's really kind of remained around that 20% range of kids who get hospitalized who require ICU admission. And then here's the percentage of kids who actually require mechanical ventilation, and that stayed very low, around 2 or 3%. So that's reassuring in terms of severity.
And the thing I would add to that, this is not just something that's happening in the lower 48. We are seeing it here in Alaska, and it does impact our kids up here. And regarding the ICU admits, one of the things is that we are learning about COVID as pediatricians and as those taking care of young kids in a different way. Before it was more, you saw more adults being impacted, and the pediatric part of it wasn't as impacted. And we are now feeling more of that impact. And as a result, we are learning more as we rely on our colleagues and our intensive care experts to help us through this. There are more protocols that we're able to use on kids that we didn't have that information earlier. So the kids are being having the advantage that we have more experience of what we can extrapolate from adult care. So it does impact here, and Alaska's feeling it the same as we would see it in the lower 48 as well.
Great. And then one last thing I'll share from this article that I think is very important is they found that they looked at the ratio of the percentage of COVID-19 associated emergency department visits among all emergency department visits and the ratio of COVID-19 hospital admissions among persons aged 0 to 17 by quartile of states grouped by vaccination coverage and age group. So this is state vaccination coverage quartile. So states with the highest vaccination rate compared to states with the lowest vaccination rate. And Alaska has the second lowest. So that's where we fall into. So the highest, and this is hospital admissions for kids. What we're seeing is that the highest is the referent group. The second highest vaccination rate in the population is a 40% increase in hospitalization risk for kids aged 0 to 17 years. And then Alaska here, we're at a 3.5-fold increased ratio of hospitalizations for children because we're in the second lowest vaccination coverage quartile. And then the highest hospital admission ratio is for the lowest vaccination coverage quartile at 3.7-fold increased ratio for pediatric hospitalizations.
One other thing that I would add to that, and to kind of build off of what Joe and Dr. Nace just shared, was, parents who are vaccinated help to protect their kiddo. So adults are more likely to spread it to kids than kids spreading it to adults. The other amazing thing is that moms who are vaccinated pass those antibodies via their breast milk. So I kind of think of it as mini monoclonal antibody infusions for their kiddo that are naturally made by mom if you're breastfeeding. So if you have a little one, I was just talking to Matsu last night, a third of their patients who are in labor and delivery were actively positive with COVID-19. That's a lot of kiddos who, may be exposed to it. So again, being able to pass antibodies to your kid and being vaccinated so you can pass those antibodies is hugely important. So we all play a role to help protect those who cannot protect themselves, ideally those less than 12 right now.
Any recommendations from our hub team for what parents can do after their children, say for example, we have a participant who shares that unfortunately their 6-year-old contracted COVID, and this parent would like to know, what they should do when their daughter recovers. Should, this parent take their daughter to get their heart and lungs examined? And, are there any specialists in state that are focusing on, pediatric COVID care?
So I'm going to turn this over to Dr. Nace. Before I do, I just want to introduce her because I think she has been a part of our team, but has kind of also jumped in here. She's an active pediatrician seeing patients on a regular basis, but has also come on as part of our school health and safety team. And it's been great to have her here and other places. You'll see more of her face as she has agreed to help us generously in the pediatric world. So Dr. Nace.
Thank you. So the question regarding once your child has had COVID-19 and it's finished the isolation phase, that 10 days, should you be seen? And the answer is yes. We are more than happy to see, because sometimes you just want questions and to be able to be answered. As far as having to see a specialist, you can start out with your regular pediatrician or family provider that you would see to check in and make sure. Now, that doesn't mean you have to do it right at day 10. We don't, if you're doing okay, we want you to wait till at least the end of that isolation period. And especially as if mom had not yet had it or dad had not had it, they might be in quarantine at that time period. So once it's a safe time period, depending on your vaccination status, and if you're in quarantine, it is completely reasonable to bring your child in, and so that we can examine and talk and say what's going on and answer those questions, because a lot of anxiety can come in with being in that position. Now, that being said, also, if your child is participating in sports and is of that age group, it's especially recommended for you to bring them in. So again, you can go over with your pediatrician or your provider that can review the things and the things to watch for and to be aware of should they begin participating in any kind of sports. So the answer to that is yes, see your regular provider. You don't need to go to a specialist. And depending on your current family status, whether you're in quarantine, isolation, where you might be in, would help you decide when that best time would be.
All right, thank you so much, Dr. Nace. So just a few more questions here related to data. Specifically, is that something that can be divided out for small communities regarding infection rate rather than pooling together for region? And we'll start there. There are a couple follow-up questions to that as well. Thanks, sub-team.
Yeah, Louisa, you want to try taking that one?
Was that for vaccine breakthroughs? Is that the question? Or hospitalizations and deaths, or the whole combination?
Cases is how I read it. Is that what you're seeing? Yeah.
Yes. Cases.
I guess we've thought a lot about presenting vaccine breakthroughs by region, and I think what we've run into is there's been such differential testing and such differential vaccination levels that you may see apparent differences that are not related to like the immunology or sort of the characteristics of the vaccine, and more for those features. And so would sort of give a misleading picture. So I think we're always sort of looking at these reports and thinking about how to present them in a way that's helpful for communities. I think other medical folks have sort of mentioned that there's no reason to think that the performance of the vaccines in Alaskans are different than other populations, and so kind of rely on that information. But as we learn more and as we kind of refine these reports going forward, it could be that there's a geographic component that's added to that. Is that kind of the question, or is it more about?
I think it's more about
Great.
cases is how I read it. And so we do put on our dashboard, any community that's greater than 1,000, you can see your case rate in that community. So there's a table and we can put that link in the chat box. Any community that's less than 1,000, we worry about the patient identification to say, you know, we had a 20-year-old in this community that's got less than 1,000. So I was reading it as cases in a specific region, and it's the 1,000 mark that we cut off on.
Okay, great. And maybe spoiler alert, the dashboard team is just always sort of looking at ways to make things just, you know, display and more helpful for users. And they are looking at an ability to kind of increase the access to sort of toggling by region for various demographic features. So hopefully, I don't have a time frame for that, but that great crew of the dashboard folks are at work sort of revamping that.
Okay, excellent. And Dr. Castrodale, we did have some additional questions about vaccine breakthrough rates. So you answered 2 for 1. Perfect. So folks are also asking for that link to the vaccine hesitancy survey, and also wondering how misinformation was being defined in that survey. Can our hub team clarify?
Yes, I believed we were going to have someone from our team on, but I don't see them. Elizabeth, can you answer that question? Or Matt?
Well, what I can say is I can go back to our data team. I know that we are working on an epi bulletin for that survey, and that's in the works. And I can get more information from our data team and share that next week.
Okay, and Erin, if you see Jessie Barker in the attendees, you can please promote her to be a hub member, and we can circle back to that question. The full survey will be released fairly soon in Epi Bulletin, like Matt said. So, and those other data will be in the slides today. Thank you.
All right, great. And then some other questions related to clarifying some of the terms within data collection. When cases are referred to as in tourism, non-residents, does that mean both workers and tourists?
No, thanks for that question. We have, as you'll notice over the last month or so, an impressive number, or more impressive number of out-of-state resident cases than we've had pretty much throughout the pandemic. And we've tagged those when we are very sure their purpose for being in the state as tourism for people who are actually tourists. We sometimes are not aware if somebody's a tourist or a worker, and so those remain unknown until we can do that. But the tourism category is for somebody who is a tourist. Thanks.
It looks like we have Jessica Barker on, which helps lead that survey. I don't know, Jessica, did you hear the question about misinformation?
If you could repeat the question, that would be great. Thank you.
Absolutely. So the question was, how is misinformation being defined in that survey?
Yeah, that's a great question. So we categorized, we went through, there was asked as an open text response, so people could write in whatever they wanted. We had 3 people going through and coding those answers. Misinformation was defined as kind of statements about vaccines that were not supported by evidence from the scientific literature, and any kind of statements about vaccines that attributed some kind of intent behind kind of vaccines to either cause harm to people deliberately. So I can give you kind of if anyone's interested, we can, when we provide the kind of full results of the survey, we'll have a definition in there of how we categorized all of those responses. So hopefully that will answer the question.
I think it does. Thank you so much. And let's see. Have comorbidities been a factor in the increased hospitalizations recently?
No, Anna or Louisa?
Yeah, so they're always a factor in hospitalizations. People, we've known from the beginning that people who have underlying health conditions are more likely to have a hard time with COVID and are more likely to need higher levels of care, and that continues to be true. I don't know that it's different than it was before now.
I think one thing we don't know about in general is it would seem that somebody who has comorbidities and is under the care of specialists or what have you probably has a lower threshold for seeking care than somebody who doesn't have any comorbidities and thinks, you know, I might just ride out this fever or what have you, and they might end up presenting later really a lot sicker than somebody with comorbidities. And so I think that also that healthcare seeking behavior also plays a factor into COVID.
Yeah, and I think I would just go back to that story that I shared earlier. Clinically, it feels like there's an increasing tale of two worlds, and that is somewhat shown in the data by the median age of those who are vaccinated versus unvaccinated. And so what we are seeing is vaccinated older individuals with many comorbidities who still get COVID, but on a good day, it takes a little thing that might push them over the edge that results in hospitalization. Urinary tract infection can be easily something that can result in someone who's older and comorbidities to result in them being hospitalized. Versus like a 45-year-old healthy person gets a UTI and, takes some antibiotics and goes to work, and it really doesn't affect their daily life nearly in the same way. And so we're seeing this kind of younger cohort of unvaccinated individuals, as Louisa said, it appears to be waiting longer to seek care for numerous reasons, because, I'm just going to wait this cold out and get better for different reasons, versus an older individual who may seek care a little bit earlier. So it is increasing the divide between the unvaccinated younger and the high comorbidity older vaccinated individuals who are both being impacted by COVID-19, but in very different ways. The other thing I think about is kind of like, like the amount of energy it takes to start a fire. And so when you get someone who's old, a lot of underlying health conditions, it's like dry wood. It doesn't take much to be able to push them over the edge. But these young, healthy people, it takes a lot to get them sick enough to result in hospitalization. And that's where I think it's been really devastating to see so many young, healthy people showing up in the hospital these days who are unvaccinated, being really sick. And I think you're hearing that in some of the healthcare stories, because those aren't the people we're used to admitting. We're not used to admitting healthy 45-year-olds or 50-year-olds. The older group we're used to seeing on a regular basis. And that's where COVID is really playing out differently than influenza or other diseases we see.
All right, let's talk a little bit about long COVID. Is there any data on whether vaccinated breakthrough positives are getting long COVID?
Joe, you want to take that one on? Or Dr. DeMeo?
Sure. Yes, thank you for that question. So there was a good study that just came out of the UK, and it's entitled Risk Factors and Disease Profile of Post-Vaccination SARS-CoV-2 Infection in UK Users of the COVID Symptom Study app. Basically, this is the first study that I've seen that really compares long COVID risk among people who have vaccine breakthrough infection versus people who have natural infection without vaccination. And what they found in this study was the risk of long COVID was cut in half if you were vaccinated and had a breakthrough case versus unvaccinated people who had infection.
And as we've seen an increased number of children test positive for COVID, has there been any update on how many of them develop long COVID? And let's also just confirm that when we're talking about pediatric cases, we're talking about folks under 18.
Great, thank you for that. There's another study that just came out. This one came out of JAMA on the 7th of September. Is that today, I guess? Is today the 7th? No, today's the 8th, so it's yesterday. Long-term symptoms after SARS-CoV-2 infection in children and adolescents. It's a small study. It was done in Switzerland, but it's the first study I've seen that really kind of systematically tries to look at this. And what they found is the risk of long COVID in children is low. They found about 4% of children in this small study who were seropositive for COVID developed long COVID symptoms. And so that is one study, and there certainly we're awaiting additional studies that are going to be larger and have a lot more kids in them. But this study is definitely reassuring on that front.
I can also tell you, just with talking with colleagues, there are special clinics in some larger cities that are specifically there for kids with long COVID. So there's enough that there is becoming a smaller specialty of people who are getting more experience with dealing with it and giving families a place to reach out to should their kid be having trouble with that. So I agree, there's not a whole lot of studies. It's a smaller percentage than with adults, but it does exist and some kids are having it. So there are resources should those be needed.
All right, a couple questions related to contact tracing and testing. So for example, in a school setting, should school staff take into account time for exposure to COVID versus exposure to a specific person? This participant asks, for example, if Tim tests positive on Thursday and his classmate Fred tests positive on Friday, would Jimmy, who had 7 minutes of contact with Fred and 8 minutes contact with Tim, which totals 15 minutes of COVID exposure, but to different people, should he be considered a close contact? And is this something that districts are taking into consideration when considering close contacts? I know that was a bit of a math problem there, so if it needs a repeat, just let me know.
Yeah, it reminds me of my 6th grade math, and there's a fox and a river involved somewhere here as well. But Louisa, you want to answer that one?
You know, I would ask for a lifeline from the school health team, because I think they work through a lot of these scenarios with individual school districts. I think a lot depends on what other mitigation measures are present at the school, the age of the kids, vaccination status. And I think there are a lot of proactive things that the schools are doing with contact tracing. So I don't know, Michelle, you look like you're smiling. So I am punting to you, school health guru. Thank you.
So it is a great question. It's going to be a difficult one to. There are some areas with contact tracing that, of course, are gray areas. And so by definition, it's greater than 15 minutes, less than 6 feet. But there are some exceptions to that rule. Where both people masked, was it 3 to 6 feet? So there are some exceptions that it's going to sometimes take a lifeline to be able to call out and say, here's the situation, let's go over together. And many districts do have those people who are champions and it can be able to help you discern that. But if the question is, if you were exposed to someone 7 minutes who was positive, another person who was 8, we would probably include that as a close contact because you had 15 minutes exposed to someone who was positive. But some of those situations can vary, again, depending on who you're with. So I would encourage you to reach out. And if you have questions, then we can help with being able to process. But in generally, we are really reaching out to the schools to help with the contact tracing part. Public health is not given the number of cases, as well as teachers, principals, school nurses right there on the front lines to be able to help and ascertain exactly what is the scenario. And public health can be resources to review over it and to be able to further make those decisions about who's a close close contact versus exposure, but truly is a difficult, and it is going to feel like sixth grade and you have a word problem and someone's traveling this way and there's a wind going this way. And we are here to help that.
And the only other thing I'd add is the schools, every district's different and they are struggling under the weight of this too. So we appreciate the patience, but please continue to be kind to your school nurses who are trying to figure this out, and where Jimmy and John and Tim all were, even if they told them the right thing or told them the wrong thing and they might be friends with someone else. So your support as parents can make a big difference in this, getting your kid tested as soon as they have symptoms, continuing to have your kid go to mask into school can make a big difference. So thanks to the schools who are working really, really hard these days to try to help us keep kids in school and COVID out.
Hub team, could we perhaps link to the CDC in-school guidance related to close contacts, indoors, outdoors, etc.? And I also know that from our school health echoes, we've had a couple pretty handy visual aids in terms of determining close contacts and when to test and those sorts of things. Perhaps we could compile those and make those available for folks in the box folder for today's session.
Yeah, and we'll also include them in next week's session as well. So come back next week, and looking at Elizabeth, we'll include some pretty graphics that the school team made to help clarify that for next week as well.
Excellent, thank you so much. So how long are contact tracers taking to get presently to a positive case? This participant shares that they heard from somebody that tested positive and it was a week later and nobody was contacted at all. And they just want to know, how are we doing on notifications?
Louisa?
Yeah, I mean, I can say that there is backlogs in along every step of the way. So the clinics are having trouble, where we used to be getting reports sort of daily or, within a day of a test from clinics. They're also backlogged and taking a couple more days, couple extra days to get their data to us. It's taken us a couple extra days to get sort of review all that data. And then the contact tracers are obviously getting this huge bolus of cases to work through. So, I mean, I think we've been messaging this for a couple weeks now. It's possible you may not get a call, depending on the timing of all that. Contact tracers are prioritizing those cases that have come in very quickly so that they can respond to those quickly. And those that are getting to them, a week later, those folks may not actually ever be outreach. So we're, the place where you had your test, their information to you, the result of that test should be coming back to you more rapidly than a contact tracer. And that may end up be where you get your education in addition to sort of what you can find and what materials are available online. And I guess as far as, I don't have numbers and I don't know that somebody from public health nursing is on, but just as far as the, I'd say the case backlog that we have is probably a couple days, maybe 3 days or so, just getting those results in and turning them around. But like I said, it's sort of, the clinics are also stretched too, because there are human beings there that have to help and get the data to the state to be counted. So, there's delays in all along the process.
Yeah, and so just to emphasize, if it's been more than 10 days from your positive, you likely won't be contacted by a contact tracer. Your infectious period has ended at that point. We're really trying to keep those who are actively infectious from moving to others and let those contacts know. So we're really prioritizing that early time frame and window. So thank you for all that you're doing to stay home if you're sick. Letting your close contacts know, it makes the whole process go much easier and helps to slow the spread overall.
All right, let's see. So are employers presently required to inform employees of cases in their offices? What are the guidelines for that? Thank you so much.
Yeah, I'm happy to start, or others are happy to chime in. It's up to that individual employer and their own legal authority. So that really depends on the nature of your employment. None of us here are lawyers. I'm looking around the room and we are all, healthcare professionals, and that it is really a legal component for sharing that information. I don't know, Brian, Fisher, or Joe, do you have anything else you would add in that space? No? Okay.
I can comment a bit because I have a private office. And we've had that circumstance when we've had individuals that became infected. They were obviously sent home, and then we notified the staff that there was an individual that they had potentially had contact with, but we don't use the name of that individual. We look at where they worked, if they worked in that same region, like if they were in the billing office, for example, we would let the billing office know that there was a potential contact. So we just don't use the person's name. It becomes obvious when someone doesn't come to work for 10 days, but we just don't use the name.
All right, thank you so much. So lots of questions about the Mu variant. Is that being tracked presently?
All you, Jamie.
Yeah, sure. Okay, so Mu is not new in Alaska. It just got a new designation and a new name. So it was B1621, and we've been tracking this since our first characterization early May. It is a virus that we noticed had the same sort of mutations as some of the variants of interest and concern. So we were sort of wondering when it would get designated. So we've been sort of watching it closely. We did have a lot of cases of Mu since May, but we've seen a really sharp decline since Delta's moved in. So at this point, I think we've added one Mu case to the report for this week, but 242 characterizations of Delta. So we're really seeing a decline, and I've heard in other states as well, not seeing Mu and Alpha as much anymore as we're seeing Delta sort of overcrowd all the other variants. I hope that answers. There's a lot of Mu questions in there, so if there's other, let me know.
All right.
This is Joe McLaughlin. Maybe I can just add a few things about Mu. So that variant it was one of the first variants of SARS-CoV-2 that basically it was identified first in Colombia in January of 2021. And Jamie, our first case was early May, right? Oh, there we go.
Correct. Yeah, I wanted to bring this up so you can kind of see we've redesignated where this used to be a blue bar at B1621. Now we're designating that as Mu. So you can kind of see how it's being crowded out by all of these Delta variants that we're detecting now.
And so the WHO says that the variant has mutations that indicate a risk of resistance to the current vaccines and really are calling for additional studies to be done. And so we're watching Mu closely. Right now, our number one concern is the Delta variant. 99% of all the cases that are sequenced come back positive for Delta in the United States and here in Alaska, but we are continuing to keep a close eye on this Mu variant.
All right, thank you so much. So let's see here. Let's talk a little bit about boosters versus third dose. We've had a couple questions come in asking about the distinction between those things, and then some developments with approval of new vaccines and the really common question as to what vaccines will soon be available for the under 12 age group. So again, let's start with the boosters and that third dose.
Matt, Kelsey, go for it.
Sure, I'm happy to start, and others please feel free to chime in. In terms of the difference between the additional dose, the third dose, and boosters, so the third dose is recommended for moderately to severely immunocompromised individuals. And so really with 2 doses, it was found that they didn't get the protection needed. And so a third dose was recommended by the Advisory Committee on Immunization Practices. And so that recommendation was made on August 13th. In terms of boosters, boosters are recommended when you see a waning in immunity. And so really to kind of get you back up to having that protection. And so really kind of, if you think of vaccines, tetanus needs a booster every 10 years. And so we do have vaccines that do need boosters. And so what we're waiting on in terms of that is for the FDA to authorize boosters. We're expecting that sometime in mid to late September. And then we expect that the Advisory Committee on Immunization Practices will then recommend that booster. So we're waiting for those 2 things to happen. And we don't know if boosters will be recommended for the entire population or if they will be recommended for subgroups of the population. For example, long-term care facilities or those that are 75 years and older. So we're really looking to the Advisory Committee on Immunization Practices to make those recommendations. Kelsey, what would you add to that?
Nothing, that was a great update.
So I'll answer the kids under 12. We do know as Pfizer have completed their trials in kids 12 and up, they finished enrolling. They're still doing the follow-up and they're still analyzing data. That's the good news because we're more on a set timeline. Before that happened, we were sort of always 4 months out. rolling. I'm still thinking November. I'm actually kind of changing it a little bit to say November at the earliest. My big hope is that we can get kids 5 through 11 their first dose before the end of the year. I would be kind of surprised if it's later than that, but as we kind of move along, we'll get a better idea of timeline.
The only other thing that I would add to that is, we try to make all of our decisions based on the best information we have at the time. And we're always looking at different articles and letters and information, but we need these trials to be completed before we can recommend vaccine for the under 12. So we are excited for the trials. We're grateful for the parents and kids who enrolled in the trials, but I've been getting a lot of questions recently, like, are you recommending it for children less than 12? No, we don't have the data. We need the data first before that group, before we can recommend it for that age group. So we'll follow it closely. And as soon as we have it, we'll be happy to share.
All right, we only have a couple of minutes left, but we do have a few questions here generally related to accessing testing. So is there a place people can go to find out what testing resources exist in their areas, specifically free ones? Thank you.
So we do have a state testing map. I encourage everyone to look at that. Testing has been kind of all over the place through the whole pandemic. The communities that tend to have the most robust testing are the ones with strong partnerships across public and private sectors, people really working together to create infrastructure. I'll put the testing map in chat, but I also remind people there are at-home options. A lot of those do count for travel. Wherever you're traveling to, look at what their requirements are, but places like Canada and Hawaii and Europe and Asia, and like a lot of these places do have at-home kits that count. You can order, they ship it to your house, you test yourself, you ship it back. You don't have to wait in line. You don't have to go through all of that for travel.
Excellent. And on that resource, the testing site locator, Dr. Cutchins, are folks able to differentiate between the testing options, like PCR versus others?
Most of them, I will say, a lot of our testing in this state has moved to a TMA, which is a molecular test, a great test. It's highly specific, highly sensitive. It's technically not a PCR. Most places do accept TMA. I have heard of a few reports of Middle Eastern countries that absolutely only require a PCR. If that's the case, there are some at-home options that are PCR. A lot of places have moved to TMA because in a lot of ways it's kind of a better test for them to operate. It's less staff intensive to do.
All right, thank you so much. So we are at 1:01, which means we unfortunately have to close out our session, but I will go ahead and ask if there are any additional updates or thoughts from our hub team before I close us out.
Thanks as always for participating. Thank you for your great questions. It helps us to inform our next one and our response. Please take a look in the chat box if your question might have been answered via text. So I can see the team putting in lots of answers as we're also going through. So check there if you haven't already, and we will see you next week. And if you're a healthcare provider, we'll see you tomorrow. Okay, thanks.
Yes. Excellent. All right, just a note to our participants, we have started compiling the questions that we've received during our session, along with the answers, both typed or indicating that they were answered live in chat. A summary of those questions, as well as resources shared during the session, will be available via the box folder that's presently linked in the chat box, and we really encourage folks to utilize that. It's a great way to look at all of the questions that have been addressed during the session and compiled nice and neatly for you all. So, all right, again, echoing Dr. Zink's thanks for everybody's attendance today. A reminder that the next session in our series will be next Wednesday, September 15th from 12 to 1. And we're looking forward to seeing you next week. And in the meantime, take care of yourselves and each other. Take care, everyone.